Hi dear student. Hi dear students. Today is our third lecture of diagnostic radiology. The subject of our today's lecture is radiology of dental disease. Okay. Interpretation of radiographs can be regarded as an unraveling process and carrying all the information contained within the black, white and gray radiographic images. The main objectives are to identify the presence or absence of disease, to provide information on the nature and extent of the disease, and to enable the formation of a differential diagnosis. To achieve these objectives and maximize the diagnostic yield, interpretation should be carried out under specific conditions following ordered systematic guidelines. Okay. The essential requirements for interpreting dental radiographs can be summarized as follows. Optimum viewing conditions, understanding the nature and limitations of the black, white and gray radiographic image, knowledge of what the radiographs used in dentistry should look like so a critical assessment of individual film quality can be made, detailed knowledge of the range of radiographic appearances of normal anatomical structures, detailed knowledge of the radiographic appearances of the pathological conditions affecting the head and neck, a systematic approach to viewing the entire radiograph and to viewing and describing specific lesions, and finally, access to previous film for comparison. Successful interpretation of radiographs, no matter what the quality, relies ultimately on clinicians understanding the radiographic image, being able to recognize the range of normal appearances as well as knowing the salient features of relevant pathological conditions. Okay. First of all, I would like to talk about radiology of developmental abnormalities of teeth. There are many developmental abnormalities that can affect the teeth and facial skeleton. In most cases, clinicians need little more than to be able to recognize these abnormalities, the recognition being based on both the clinical and radiographic finding. Dental anomalies include variations in normal number, size, eruption, or morphology of the teeth. Developmental abnormalities occurred during the formation of the tooth or teeth. Most of the defects considered are inherited. Acquired abnormalities result from change to teeth after normal formation. Okay. First type of developmental abnormalities is abnormalities of number and eruption. They are supernumerary teeth, missing teeth, and tooth impaction. Supernumerary teeth. These are extra teeth that appear in addition to the regular number of teeth. They are also called supplemental teeth when they have normal morphology, mesiodonts when they occur between the maxillary central incisors, parateeth or paramolar, those occurring in the molar area, distodonts or distomolar, those that erupt distal to the third molar, periodonts supernumerary teeth that erupt ectopically, either buccally or lingually to the normal arch, and common region of the jaws to be affected is the premaxilla. That's this type of anomalies we can find usually in premaxilla. Okay. In this picture you can see X-ray picture, X-ray film different tooth anomalies such as mesiodonts, as you can see here, paramolar blacking, the eruption of third molar, mesiodonts also, and distomolars, as you can see here, in right and left side. Okay, in this picture you can see clinical and radiographic view of mesiodonts, clinical view and radiographic appearance of them. Okay. Usually, supernumerary teeth characteristically found in cleidocranial dysostosis. In this patients, one of sign of this patients is absence of clavicle, because we name it cleidocranial dysostosis. Okay, missing teeth. The expression of developmentally missing teeth may range from hypodontia. Hypodontia is the absence of one or a few teeth. Oligodontia, the absence of numerous teeth. Anodontia, the failure of all teeth to develop. Pseudoanodontia, when teeth are absent clinically because of impaction or delayed eruption. False anodontia, when teeth have been exfoliated or extracted. And anodontia or hypodontia associated with systematic disease, for example, ectodermal dysplasia. In this picture, you can see developmental absence of all maxillary premolars and both mandibular second premolars. The retention of the maxillary primary canine as a result of the posterior position of the maxillary permanent canine. Okay. Anomalies of tooth size are microdontia and macrodontia. Microdontia has three forms: true generalized microdontia, relative generalized microdontia, focal or localized microdontia. In this picture you can see true generalized microdontia. In this picture you can see clinical view of this patient. All teeth are smaller than normal, occur in some cases of pituitary dwarfism, exceedingly rare, and teeth are well formed. Second type of this anomaly is relative generalized microdontia, with normal or slightly smaller than normal teeth, and in these patients are present in jaws that are somewhat larger than normal. And focal or localized microdontia, it's a common condition, usually affects maxillary lateral incisor third molar, and these two teeth are most often congenitally missing. Okay. Focal or localized microdontia, usually they can found sides converge or taper together incisively, forms cone-shaped crown, root is frequently shorter than usual. Macrodontia, the teeth are larger than normal, or the teeth are of normal size but occur in smaller than normal jaws, and has three main types: true generalized macrodontia, relative generalized macrodontia, focal or localized macrodontia. In this picture you can see X-ray film of macrodontia. Okay. True generalized macrodontia, all teeth are larger than normal, associated with pituitary giantism, and exceedingly rare. Okay. Relative generalized macrodontia, normal or slightly larger than normal teeth in small jaws result in crowding of teeth, malocclusion, and impaction also may occur. And the third type of this anomaly, focal or localized macrodontia, this uncommon condition and unknown etiology. In this picture, you can see clinical and radiological appearance view of macrodontia. Okay. Anomalies of tooth eruption. First of them is transposition. Transposition is the condition in which two teeth have exchanging positions. Frequently transposed teeth are the permanent canine and first premolar. Second premolars infrequently lie between first and second molars. The transposition of central and lateral incisors is rare. Altered morphology of teeth. Fusion. For example, fusion of teeth results from the combining of adjacent tooth germs resulting in union of the developing teeth. Or fusion results when two tooth germs develop so close together that as they contact and fuse before calcification, or a physical force or pressure generated during development causes contact of adjacent tooth buds. Appears as a single large tooth structure which may involve entire length of teeth or may involve roots only, where the cementum and dentin are shared. In this picture you can see all these parameters, all these signs. Clinical and radiographic picture of fusion. As you can see here, clinical view and radiographic view. Germination or twining. Germination is a rare anomaly that arises when the tooth bud of a single tooth attempts to divide. The result may be an invagination of the crown with partial division, or in rare cases complete division throughout the crown and root, producing identical structures. Complete twining results in a normal tooth plus a supernumerary tooth in the arch. Cause of this pathology is unknown, or it may be familial. The patient has a larger tooth but a normal number of teeth overall, in contrast to fusion, where the patient would appear to be missing one tooth. Okay. Management of this pathology is affected teeth can cause malocclusion and lead to periodontal disease. The affected tooth may be removable if it is deciduous tooth. The crowns may be restored or reshaped, or the tooth may be left untreated and periodically examined to preclude the development of complications. In this picture you can see this pathology in occlusal view. And in periapical view also you can see it. In this picture you can see fusion of the left mandibular, central and lateral incisors, germination of right mandibular central incisor has one root canal and partially with dental crown. Taurodontism. Taurodontists have longitudinally enlarged pulp chambers. The crown is of normal shape and size, but the body is elongated and the roots are short. The pulp chamber extends from a normal position in the crown. It may be associated with oral facial digital syndrome, amelogenesis imperfecta, and type 4 Down syndrome. Okay. Delaceration. Delaceration is a disturbance in tooth formation that produces sharp bend or curve in the tooth. Causes are trauma to the calcified portion of a partially formed tooth or due to true developmental anomaly. In this X-ray picture, you can see the lacerated root. The apical portion of tooth of the root is bent backally or lingually into the plane of the central ray. Okay. Other type of anomaly is dense indent or invaginated odontoma. It is an unfolding of the outer surface of a tooth into the inferior, usually in the cingulum pit region of maxillary lateral incisors. It is of two forms, coronal and radicular types. Clinically varies from slight enlargement of cingulum to a deep infolding that extends to the apex. It has been classified into three major types, as you can see here. First type is confined within the crown of the tooth and does not extend beyond the level cement-enamel junction. Type 2 extends below cement-enamel junction and in unblind sac may or may not communicate with adjacent dental pulp. And type 3 extends through the root and communicates laterally with the periodontal ligament space through a pseudoforamen or at the apical foramen. And there is usually no communication with the pulp which lies compressed within the root. Okay, in this picture you can see clinical and radiographic view of this anomaly, dense into the dent. Okay. Most cases of dense indent are discovered radiographically. It is more radio-opaque than the surrounding tooth structure and can easily be identified. Okay. Dense evaginatus. In contrast to the dense indent, dense evaginatus is the result of an outfolding of the enamel organ involving an extra cap or tubercle that protrudes from the tooth. Premolars are more likely to be affected than any other tooth. Located an occlusal surface between buccal and lingual cusps of premolars, it may be unilateral or bilateral. Cause is unknown but is thought to be a result of genetics or a disruption of the tooth during formation. Okay, in this picture you can see dense evaginatus, clinical, as you can see here, and X-ray picture, bite wing view, on periapical view. You can also see it. Also, this patient has periodontitis also. In this periapical view, you can also see dense evaginatus. Okay. Now, I would like to talk about radiology of inflammatory disease. First of them is caries. Caries is a bacterial invasion of the tooth which first liquefies a narrow tract through the enamel and then causes more extensive softening and staining if the adjacent dentin. It attacks the occlusal surface of molars, the neighboring surface and the neck of the tooth where carbohydrate food residues have been allowed to remain. Radiographic interpretation of dental caries should always be undertaken with a clinical examination of the oral cavity. It's so important. Caries is detected radiographically only in the advanced stages when there is sufficient decalcification of tooth structures. A radiographic diagnosis of caries must always be supplemented with a careful clinical examination. In this picture, you can see radiographic staging of caries. As you can see here, stage 1, radiolucency into the outer half of the enamel. Stage 2, radiolucency in the inner half of enamel. Stage 3, radiolucency up to the enamel dentin junction, as you can see here. Stage 4, radiolucency with slight extension into the dentin. Stage 5, radiolucency into the outer third of the dentin. Stage 6, radiolucency into the middle third of the dentin. And finally, stage 7, radiolucency into the inner third of the dentin. This is stage 4 classification of radiolucency in dental caries. Okay. In this picture, you can see also a classification of caries depending on stages. Incipient caries, lesions that extends less than halfway through the enamel. Moderate caries, lesions that extends more than halfway through enamel but does not involve the dentin enamel junction. Advanced caries, lesions that extends to or through the dentin enamel junction but does not extend more than half the distance to the pulp. And finally, severe caries, lesion that extends through enamel, through dentin, and more than half the distance to the pulp cavity. Okay, in this picture you can see classification of dental caries with localization of them, interproximal caries, occlusal caries, buccal or lingual caries, root or segmental caries. For diagnosis of caries, we can use from different radiographic techniques. Radiographs are often essential for the early detection of interproximal caries. The caries process results in demineralization, which is radiolucent, because the caries lesion attenuates the beam less than healthy to structure, resulting in more of the remnant beam reaching the film to produce more interaction in the emulsion layer, thus producing more black metallic silver. This caries appears on X-ray film as translucent, as dark points, dark areas. Important radiographic techniques are posterior Birdwing views, periapical views, and panoramic views. Okay. The frequency that radiographs are required can be determined only clinically and by taking a history. Such factors as oral hygiene, diet, history of caries, and age are important. Radiographs food caries should be taken at 1 to 2 year intervals in adults depending on the above factors. In young children, one can consider taking radiograph every 6 to 12 months on caries-prone children. When a new patient is seen, it is important to find out when the last radiographs were taken. If present, one should attempt to obtain them before attempting retakes. Radiographs of inferior quality should be ignored and retaken. In this picture, you can see interproximal caries of upper right first and upper right second tooth. Also deep caries extending to pulp cavity. Caries lesions are detectable radiographically only when there has been enough demineralization to allow the lesion to be differentiated from normal enamel and dentin. Okay, in this picture, in bite-wing view, you can see the proximal caries on the maxillary second premolar. Also, you can see on this periapical radiography, the proximal caries is not clearly visible as on the bite-wing view. Occlusal caries on an mandibular molar. In this picture, you can observe the diffuse triangular appearance of the caries with the base of the triangle at the dentin enamel junction and the apex towards the dental pulp. Okay, proximal caries on maxillary and mandibular second premolars, first molars and second molars. Also, you can see caries is much larger clinically than seen on the radiograph. Okay, in this picture you can see proximal caries on anterior teeth. Root or segmental caries on mandibular first molar has a scooped out appearance. There is loss of alveolar bone height resulting in the exposure of cementum. Okay, recurrent caries underneath the amalgam restoration of the maxillary molar. You can see amalgam restoration material and caries. Presence of secondary dentin between the recurrent caries and the pulp chamber also. Okay. Radiographic interpretation of dental caries is not always straightforward. It is often complicated by two additional radiographic shadows: radiolucent cervical burnout or translucence and the radio-opaque zone beneath amalgam restorations. So important in this aspect is cervical burnout. Cervical burnout can be explained by the considering all the different parts of the tooth and supporting bone tissues that the same X-ray beam has to penetrate. In the crown, the dense enamel cap and dentin. In the neck, only dentin. In the root, dentin and the buccal and lingual plates of alveolar bone. Cervical burnout is of diagnostic importance because of its similarity to the radiolucent shadow of cervical and recurrent caries. However, burnout can usually be distinguished by the following characteristic features. It's located at the neck of the tooth, demarcated above by the enamel cap or restoration and below by the alveolar bone level. It's triangular in shape, gradually becoming less apparent towards the center of the tooth, and usually all the teeth on the radiographs are affected, especially the smaller premolars. In contrast, root and recurrent caries lesions, although they also often affect the cervical region, have no apparent upper and lower demarcating boulders. Okay, radiology of periodontal tissues and periodontal disease. An overall assessment of the periodontal tissues is based on both the clinical examination and radiographic findings. The two investigations complement one another. Like many other indications of periodontal disease, radiographs only provide retrospective evidence of this process. However, they can be used to assess the morphology of the affected teeth and the pattern and degree of alveolar bone loss that has taken place. The main radiographic projections used to show the periodontal tissues include paralleling technique periapicals, bite-wing, horizontal or vertical, normally for posterior teeth, dental panoramic radiographs where there is pocketing greater than 5 mm in depth, and digital radiography, including subtraction radiography and densitometric image analysis, which may assist in showing and measuring subtle changes in fine alveolar and crystal bone pattern. Okay. On X-ray, this pathology can appear as thin, smooth, evenly corticated marking to the interdental crystal bone in the posterior regions, thin, even pointed margins to the interdental crystal bone in the anterior regions. Cortication at the top of the crest is not always evident, owing mainly to the small amount of bone between the teeth anteriorly. The interdental crystal bone is continuous with the lamina dura of the adjacent teeth. The junction of the two forms a sharp angle. Thin even width to the mesial and distal periodontal ligament spaces. Periodontitis is a name given to periodontal disease when the superficial inflammation in the gingival tissues extends into the underlying alveolar bone and there has been loss of attachment. The destruction of the bone can be either localized, affecting a few areas of the mouth, or generalized, affecting all areas. The rate of this progression and subsequent bone destruction is usually slow and continues intermittently over many years, or it may be rapid. The radiographic features of the different forms of periodontitis are similar. It is the distribution and the rate of bone destruction that varies. Okay. Periodontal disease is initially a gingivitis. This may be acute. If the inflammation persists, resorption of the peaks of the underlying interdental bony papilla can result, and this may be demonstrated radiographically. In these diagrams, you can see various radiographic appearance of periodontitis. In this picture, you can see early loss of the corticated crystal bone, widening of the periodontal ligament space, and loss of the normally sharp angle between the crystal bone and the lamina dura. In picture B, you can see moderate horizontal bone loss. G, extensive horizontal bone loss with furcation involvement. In picture D, localized vertical bone loss affecting. And finally, you can see extensive localized bone loss involving the apex, as you can see here. Okay, in this picture, you can see periodontitis. On periapical radiography, you can see moderate to severe loss of alveolar bone in this region and this region. Crystal irregularities, as you can see here, and calculus, which is frequently seen with periodontal tissues, and the dashed line indicates the normal level of the amelocemental junction. This normal level of them. Okay. Chronic periodontitis is most common and important form of periodontal disease, affecting the majority of the dentate and partially dentate population. It is the main cause of loss of teeth and in later adult life. The main pathological features of this disease are inflammation, destruction of periodontal ligament fibers, resorption of the alveolar bone, loss of epithelial attachment, formation of pockets around the teeth, and gingival recession. In this picture, you can see periapical radiography. Periapical radiograph shows an extensive area of bone loss and periodontal abscess also. Periodontal abscess and extensive area of bone loss. Okay. This is also X-ray films, periapical X-ray films of chronic periodontitis. In first picture, you can see early or mild and moderate bone loss affecting mandibular molars, and moderate and severe bone loss affecting maxillary molars, and these arrows, these black arrows, indicate calculus deposits. Okay. The localized severe form of periodontal disease develops in adolescence, and we name it juvenile periodontitis. Juvenile periodontitis, in this picture you can see it. So important radiographic features include severe vertical bone defects affecting the first molar and or incisors, arch or saucer shaped defects. Sometimes the bone loss is more generalized, and migration of the incisors with destemma formation and rapid rate of bone loss. Okay. In this picture, you can see chronic periodontitis, enlargement of periodontal ligament space and formation of abscess with non-corticated margin associated with carious tooth or dental restoration, and widened periodontal ligament space. Cystic lesion. First of all, I would like to talk about inflammatory odontogenic cysts. First type of this cyst is radicular or dental cyst. Usually we can find it in adults. Most common of all jaw cysts, about 17% of all jaw cysts. Usually they can find apex of any non-vital tooth, particularly upper lateral incisors. Size of them is 1.5 to 2 centimeter in diameter. Shape is round and monolocular. Outline is smooth, well defined, with well corticated if long standing, and continuous with the lamina dura of the associated tooth. And on X-ray film they appears uniformly as radiolucent areas, dark points, and in this X-ray film you can see these types of cyst, radicular cyst. This panoramic radiography, and on panoramic radiography you can see typical radicular or dental cyst associated with the non-vital tooth, and in second picture you can see typical monolocular radicular cyst associated with the non-vital tooth also. Okay. Next type of cyst is residual radicular cyst. This term refers to a radicular cyst remaining after the causative tooth has been extracted. Usually we can find it in adults 20 years old and older, in apical regions of the tooth bearing portion of the jaws. The size of them is variable, usually from 2 to 2 centimeter in diameter. The shape is round or monolocular. outline is smooth, well defined, usually well corticated, and on X-ray film they also appear as radiolucent areas. Okay, in this picture on you can see two residual radicular cysts on the maxilla and in the mandible. The mandible and maxilla, you can see it. Okay. Developmental odontogenic cyst or lateral periodontal cyst, one type of them is lateral periodontal cyst. The diagnosis of this rare developmental cyst should be reversed for a cyst in the lateral periodontal region that is not an inflammatory cyst or an atypical odontogenic keratocyst. Usually we can find it in adults over certain years old. Usually they can found in lateral surface of the roots of vital teeth in the lower canine premolar region of upper lateral incisor region. Size of them is small, less than 1 centimeter in diameter. Shape is monolocular, very occasionally multilocular and round. On X-ray film they appear as radiolucent areas. Okay, in this picture you can see it. This periapical radiography shows typically small lateral periodontal cyst, and although the adjacent premolar was restored, it was vital and without signs. Okay. Follicular cyst. This cyst develops from the remnants of the reduced enamel epithelium after the tooth has formed. Usually we can find it adolescents or young adults, and usually they can found associated with the crown of an unerupted and displaced tooth, typically teeth where eruption is impeded. Size of them is very variable, suspected if follicular space exceeds 3 centimeters, but may grow to several centimeters in diameter and extend up into the ramus. And the shape of them is round or oval, typically enveloping the crown symmetrically and monolocular. And on X-ray film they appear uniformly radiolucent. Okay, in oblique lateral of the right side of the mandible you can see this picture. You can see typical circumferential cyst associated with the unerupted and displaced tooth. And in second picture you can see it is also part of digital panoramic radiography, showing a monolocular central cyst associated with the unerupted and inferiorly displaced tooth also. Okay. The next type of cysts is odontogenic keratocyst or primordial cyst. This cyst develops from the epithelium of the dental lamina, the cell rest of serous, instead of the normal tooth, which is therefore typically missing from the series. Age of patient is very variable, peak incidence between second and fourth decades. Usually they can be found in posterior body angle of the mandible extending into the ramus. Size is variable but often large in the mandible. Shape of them is oval, extending along the body of the mandible with little mediolateral expansion. Usually we can find them uniformly radiolucent areas. In this picture, in oblique lateral of the left side of the mandible, you can see typical extensive pseudolocular odontogenic keratocyst. This picture you can see it, and the next picture you can see And in part of oblique lateral view, you can see dumbbell-shaped odontogenic keratin cyst. Okay. Now I would like to talk about typical radiographic features of tumors and tumor-like lesions. Okay, first of them is ameloblastoma. Ameloblastoma is aggressive but non-metastasizing tumor originating from remnants of the odontogenic epithelium of the enamel organ or dental lamina. Peak age is about 4 years old. Usually we can find it in posterior body angle ramus of mandible, very occasionally involves the maxilla. Size of them is very variable depending on the age of the lesion, may become very large if neglected and cause cross facial asymmetry. Shape of them is multilocular, distinct septa dividing the lesion into compartments with large, apparently discrete areas centrally and with small areas on the periphery, and they appear in all X-ray films as radiolucents with internal radioopaque septa. In this picture, this is part of digital panoramic radiography. You can see the typical multilocular appearance of a large ameloblastoma at the angle of the mandible with extensive expansion and resorption of adjacent. Okay. Radiology of intrinsic primary malignant bone tumors. And one of them is osteosarcoma. Osteosarcoma is rare, rapidly destructive malignant tumor of bone. From a radiological viewpoint, there are three main types: osteolytic type with non-neoplastic bone formation, osteosclerotic type, neoplastic osteoid and bone formed, and mixed lytic and sclerotic type, patches of neoplastic bone formed. Usually we can find it in young adults under 13 years old. Usually they can localized in the mandible. Size of them is variable and shape and outline also is variable, and depending on type of them, radiodensity is also variable. Okay. In this picture, you can see periapical radiography showing a purely dent-ridged area of radiolucency with resorption of the lateral aspect of 12 root, biopsy revealed an osteolytic osteosarcoma. And the next patient, periapical view shows a similar smaller poorly defined area of bone destruction, and which was again shown on biopsy as osteosarcoma. Okay. Secondary or metastatic bone tumors. Carcinomas from the bronchus, breast, and prostate, kidney, and thyroid sometimes metastasize to the JAVs and produce the typical destructive radiolucence of a malignant lesion. That's these tumors, they has two types, primary and secondary tumors. Usually secondary metastatic bone tumors. The first origin place of them is carcinoma of the bronchus, breast, or prostate. Usually the age of these patients is over the 14 years old. Usually we can find it centrally in the mandible, molar, and premolar regions, occasionally at the apex of tooth. Size of them is variable, dependent on the length of time the lesion has been present. Shape of them is irregular and irregular area or areas of bone distraction. Outline of secondary or metastatic tumors is irregular and moth-eaten, poorly defined, not corticated, and radiodensity is also variable, radiolucent, but some carcinomas from the prostate and breast may be osteogenic and show areas of bone production or sclerosis. Okay. Right side of digital panoramic radiography, you can see typical distractive moth-eaten radiolucency of a malignant lesion. Underlying soft tissue involvement is also evident. Subsequent investigation showed this to be a secondary metastatic tumor from the breast. Its primary tumor is breast cancer, and this metastasis of breast cancer. Okay. A left side of digital panoramic radiography and posterior anterior job view of the same patient showing a poorly defined radiolucent secondary metastatic deposit from the lung presenting centrally in the ramus. This patient has a primary lung tumor and this metastasis of them. Okay. Multiple myeloma. This multifocal proliferation of the plasma cell series within the bone marrow resulting in overproduction of immunoglobulins. The age of patients usually is in middle-aged patients we can find it. Usually we can find it multiple lesions in skull, posterior parts of the mandible and other parts of the skeleton. Size of distractive areas is variable. Individual lesions may be several centimeters in diameter. Shape of them is round, monolocular or multifocal. Outline is punched out, well defined and not corticated, and they can found in all X-ray methods as radiolucent areas. Okay. This X-ray picture, lateral skull X-ray picture of multiple myeloma. Two lateral skulls showing the typical multiple punched out lesions of the skull wall of this disease, and in B picture oblique lateral of the left side showing two similar lesions in the mandible. This typical appearance of multiple. Okay. Radiology of trauma to the teeth and facial skeleton. Injuries to the teeth and facial skeleton are unfortunately common. The type and severity of injuries can vary considerable, from minor damage to the teeth to grossly comminuted fractures of the skull. Whatever the suspected injury, radiography is an essential requirement both in the initial assessment and in the follow-up appraisal. However, the radiographic examination may be restricted and limited by the general state of the patient and the type and severity of other injuries. For example, severe facial injuries are often associated with intracranial damage and or cervical spine injuries, the importance of which far outweighs any damage to the teeth and their supporting structures. The radiographic investigation must therefore be tailored to each patient's needs. For investigation of traumatic lesions of teeth and facial skeleton, In practice, we use from different types of radiologic examinations, from radiography, from different types of radiography to computer tomography. CAT scan, CAT scan and three-dimensional computer tomography. These methods are so important for correctly diagnosis of traumatic lesions of facial skeleton. Different types of dental injuries can be divided into fractures of the teeth, luxation injuries to the teeth, fractures of the alveolar bone, and other injuries. Although the type of injury may be evident clinically, radiographic investigation of all trauma teeth is needed initially to assess fully the degree underlying damage. Radiographs are also required later to assess healing and or the development of post-trauma complications. The ideal radiographic requirements include two views of the injured tooth from different angles, ideally at right angles to one another, but more usually with the X-ray tube head in two different positions in the vertical plane, for example, in the anterior region, a periapical paralleling technique, an upper standard occlusal, reproducible views to provide a baseline assessment and to allow subsequent follow-up evaluation, views of the chest and or abdomen if a tooth or foreign body is said to have been inhaled or swallowed, including soft tissue lateral and AP or anterior-posterior position of the larynx and pharynx, posterior-anterior PA of the chest and right lateral of the chest, and anterior-posterior film of the abdomen. That's in all cases, radiography must be taken in two positions, anterior-posterior and posterior-anterior position and lateral position of patient. The diagnostic information provided by these radiographs may include the type of injury to the teeth, the size of fractures, the degree of displacement of the tooth fragments, the stage of root development, the condition of the apical tissues, the presence, site, and displacement of alveolar bone fractures, the condition of adjacent or underlying teeth, evidence of healing, post-trauma complications including resorption, infection, cessation of tooth development, and the location of the tooth if swallowed or inhaled. Okay. The expected radiographic features indicating a fractured root include a radiolucent line between the fragments, an alteration of the outline shape of the root, and discontinuously of the periodontal ligament shadow. Okay. These radiographic films of tooth fracture, periapical view. On periapical view, you can see tooth fracture line as translucent. In this picture also, you can see fracture line, tooth fracture, also clearly invisible on periapical radiography. Okay. As mentioned earlier, radiographs are an essential part of the initial assessment and follow-up appraisal of all patients with suspected facial fractures. They are crucial for evaluation. The presence of fractures, the site and direction of the fracture line, the degree of displacement and separation of the bone ends, the relationship of teeth of the fracture line, The location of associated foreign bodies in hard and soft tissues, the presence of coincidental or contributory disease, the alignment of the bone fragments after treatment, healing, and the identification of post-trauma complications including infection, non-union, or malunion. Okay, in this picture, in this X-ray film and computer tomography, you can see anterior maxillary fracture with cortical defect and depressed fragment, okay, for investigation of skeletal trauma. So important method is computer tomography and three-dimensional type of this method. And fractures of the mandible. For diagnosis of fractures of the mandible, clinicians need to know where the mandible tends to fracture, which radiographic views are required to show each of the fracture sites, what radiological features indicate the presence of fractures, how to assess the radiographs for possible fractures. This OPT, orthoped tomography, you can see fracture of jawbone, fracture line of them. Okay. So dear students, we have already concluded lectures of diagnostic radiology. Our next two lectures will be about radiotherapy. By concluding diagnostic radiology, I should emphasize that the correct interpretation of the results of dental imaging is important to choose the appropriate treatment. You will use them in your clinical practice. Thank you for your attention.